Thank you. Good morning, everybody. Thanks to Mahesh for inviting me again this year. I really appreciate it. I love coming to Houston, especially this time of the year since it's about 35 degrees in Rochester. So I'm going to talk about annual enlargement. I just want to thank the previous speakers because they've set up all the details of mini AVR for me, and I would say that basically everything they said I agree with. A little bit different in terms of my setup. I cannulate the aorta on everybody and do percutaneous venous access, so I don't need to do a cut down. I use a chipwood clamp through a separate stab incision laterally around the fourth interspace for the cross clamp, and then a drain goes through that same port, but otherwise the setup is essentially the same. I have essentially no disclosures financially. I am a minimally invasive cardiac surgery zealot. I've been involved in minimally invasive cardiac surgery for over 20 years, really. It's a little embarrassing to show our medical center in a place like Houston, which, I mean, this is like one building for you guys, but for us, it's a major part of our community. The medical center is in the foreground, the university is in the midground, and then the city of Rochester is in the background. The Stone Age didn't end because we ran out of stones, but because we came up with something better. And similarly, we have not run out of sternums, but we have something better. I want to just talk a little bit about why surgical aortic valve replacement remains relevant and what it takes for all of us in order to maintain that relevancy. And it starts with TAVR, which is, in my opinion, one of the most important technological changes to affect cardiac surgery since the development of long-term MCS. But there are problems with TAVR expanding to the general population, and everybody's alluded to what's happened. There's been mission creep with TAVR, and there continues to be mission creep, and I'll show you the statistics there. Just want to remind everybody, line number one, it's a 1A indication for symptomatic and asymptomatic patients with severe AS and any indication for AVR who are 65 years of age and less and have a life expectancy of 20. SAVR is the recommended therapy, not TAVR. So every time we put a TAVR into a young, healthy 63-year-old or 60-year-old, we're really going against guideline recommendations. So all of your colleagues in the interventional world or cardiologists who say they do guideline-directed therapy, point out to them that AHA recommendations, it's a 1A indication for surgical AVR. In here also, which is little known, and actually when I started preparing for this talk, I didn't realize it too, for patients with a 1A indication for patients with indication for AVR for whom a bioprosthetic valve is preferred, but vascular anatomy or other factors are not suitable for transfemoral SAVR is recommended. So in the alternative access group of patients, according to current guidelines, it's a 1A indication for SAVR. And why do I tell you all this? I tell you this because this is not what we're doing as an industry. This is a paper from the Journal of American College of Cardiology. It was a couple of years ago. 800 academic medical centers, 250 that do TAVR and SAVR. There are 140,000 patients altogether. 3 cohorts, 65 to 80, and greater than 80. I'm rushing through this because I also want to show a video, but I'll draw your attention to the left-sided part of this slide where it says TAVR less than 65, and this goes from 15 to 2021. The trend continues, so 2021 was 4 years ago, 5 years ago. 47.5% of patients were getting TAVR less than 65 years of age, and this data is repeated. So our numbers at that time frame, and I'll show you the most current years, 2025 in a moment, but our numbers at that timeline were 65, less than 65, 85% were getting SAVR, and in the 65 to 80, we were still almost 40%. So this was a J. Maxwell Chamberlain paper from a year ago, guidelines versus practice, and I can tell you that our group is looking at this with Vizient data, current data, and it supports the same piece of information. This is a complex slide, but I just draw your attention to the SAVR versus TAVR. Blue is SAVR and red is TAVR, and the outcome. So TAVR associated with a 2.5-fold increased hazard of 5-year mortality in propensity-matched patients. So if you look at that curve, the upper one is survival, and the lower one is heart failure admissions, and they diverge almost right away. So not only, and I don't want to bash transcatheter valve because we've all been there where we see this patient who we really don't want to operate on, and TAVR rescues us. It's a great therapy. You know, a 102-year-old, it's unbelievable. But, you know, when it starts having mission creep down to young people, it becomes problematic. So another paper showing where sort of a composite piece of data, Vizient data, less than 65, 52% were getting SAVR, so basically 50-50 in the under 65 group, whether it be the California study, Northern New England group, all under 65, basically all the same. And then, as previous speakers have mentioned, look at Europe, France, Denmark, less than 65, it's somewhere in the 10 to 15% range. So I think our European colleagues are doing a lot better job of protecting patients from inappropriate therapy. So our numbers, this is, I had time because I was on the TSA wait list for a while, so I was able to put together this slide. In our numbers last year, in 2025, a little over 70% of patients under 65 got surgical AVR, and most notably in the 65 to 75 group, it's about 50%. So we stick to the guidelines. Most of the people in the orange had good reasons for not getting surgical AVR. So why are we successful at this? Well, for one thing, we have a great heart team. So we're very collaborative with our interventional cardiologists. The cardiac surgeons see most of these patients first, but in a collaborative clinic where they're also seen by an interventional cardiologist. So that's one factor. But this is the major thing. We don't do sternotomies. We do everybody minimally invasive. We've been doing that for probably close to 15 years now. So I would go back to the statement that I've made before, the 4 pillars of SAVR relevancy. Non-sternotomy incision, because nobody wants a sternotomy, and they'll take an inferior operation over a sternotomy. It's just the fact. So the sternotomists in the group, that you just have to come to grips with it. It's a great incision. It works really well. We've done it for decades, but people don't want it. We need to be in the low gradient business, which is how I got to this talk of annular enlargement. Preferably single digits, because that's what we're competing with TAVR most of the time. And a rigorous approach of being at least 0.85 square centimeters per meter squared of body surface area. And in order to do that, you need to be able to do annular enlargements through this incision, which, as other people have said, it's not hard. It really isn't. And we talked a little bit about paravalvular leak. That's where I have some objection to rapid deployment valves, because there is an inherent paravalvular leak with that product. We should have no paravalvular leak. That's one of the strengths of surgery. There is a underlying paravalvular leak with transcatheter valve, which doesn't seem to be, it's been lessened with improved seal zones, but still has not been eliminated. We should have 0 paravalvular leaks. And then this is the other area where we are very competitive with transcatheter valve, and that's the pacemaker rate. We should be at 1% or less in terms of pacemaker rate, and despite all the efforts that we've made for high implants and careful deployment of the valve, there's a 10% pacemaker rate with TAVR, and I'll show you why that's a factor. And it's becoming clear now in the TAVR patients what factor it is. So we know from the surgical data, this is unequivocal. I just pulled a couple of them. In terms of the impact of permanent pacemaker within 30 days after surgical aortic valve replacement and long-term survival. So I won't dwell on the details, but look in the yellow. Median follow-up was 7.5 years, and there was a hazard ratio of death of about 1.48 at that point. Similarly, a group from the Mayo Clinic, the exact same number, 1.49 at 5 years. This is a TAVR meta-analysis. So this is, beginning to hit the mainstream medical publications. Late outcomes of permanent pacemaker implantation after TAVR, a meta-analysis. The 4 panels, you can look at the upper 2 panels. The left one is mortality, and the other one is rehospitalization. And as you can see, in pacemaker patients, the mortality is higher, and the hospital admissions are even greater, and that's only at 6 years. And they will continue to diverge, and we know this, because if you pace somebody, you have an underlying bundle branch block, it ultimately results in heart failure. And who does it impact mostly? It impacts the younger people mostly, because it happens over a long period of time. So this is only going to spread more. How about AI after surgery? So, we get zero AI. TAVR gets mild, trace to mild AI. And you think to yourself, mild AI, no big deal. And you're probably right. No big deal in you and me if we're walking around with mild AI. But in the post-procedure thing, it actually impacts survival. So again, we don't know the details of this in the TAVR patients yet, but we know it in the surgical group. So the impact of residual regurgitation after aortic valve replacement, again in the yellow, at all time points, aortic regurgitation resulted in increased long-term mortality with a hazard ratio of 1.7. So if you and these were not moderate and severe, because if you have moderate, as people have already articulated, if you have anything more than mild in the operating room doing surgical AVR, you've got to fix it. So these were all in trace to mild patients, and the hazard ratio 1.7. I mean, it's not uncommon on the post-op echo from tomorrow when you're of your TAVR today that you see mild AI, and it's going to have an impact. Not in the 81-year-old probably, but in the 61-year-old almost for sure. So again, the relevance of surgical aortic valve replacement is dependent on small non-sternotomy incisions, single-digit mean gradients, which means the ability to do annular enlargement, zero paravalvular leak, and minimal pacemaker rate. I show this slide a second time because I feel very strongly about this. We as surgeons need to commit to this. So in our series, I don't know how many mini AVRs this included actually, but the number of the current number of annular enlargements is 74. The mean age was 65. The BMI is 34. BSA is about 2. It's in the same group of patients that you'd expect. They're usually a little bit obese or a lot obese, so their BSA goes up, and they have annuluses that are fairly small. 82% were female. I think that you'll see that as a frequent trend too, because women have smaller annulus than men. There are associated diseases of subaortic membrane. We did one coronary bypass in that group. Because as you're aware, you can probably do an RCA pretty easily through the right thoracotomy. Most of them were first surgery, but second surgery and third surgery were a couple of cases. I do re-op mini AVRs on most patients that have had prior AVRs or prior coronary bypass surgery. It's really pretty straightforward. And it's easier to enter safely than to redo sternotomy. These are the spectrum of valve sizes. The mean gradients were 41 preoperatively and 10 post-op. The clamp time is relatively long. It's about 2 hours. Keep in mind I'm in a residency training program, so at least some of this operation is being done by I-6 residents. Length of stay is reasonable at post-op length of stay, reasonable at around 5 days. This is the cardiopulmonary bypass times, and they're relatively long, 160 minutes. But again, I don't find time to be a real major factor. In the modern era of myocardial protection, I don't think it makes much difference as long as you're not going, 4 hours. In terms of our outcomes, no paravalvular leaks, no patient prosthesis mismatch. We converted the sternotomy 3 times. All of them were early in the experience. And as has been mentioned before, and I think Mahesh mentioned it, conversion to sternotomy is not a failure. You hit a point where you have to make a good choice. And I urge everybody to take a breath, as Mahesh pointed out, assess the situation, and make a good choice. Because in cardiac surgery, as you all know, because you've been doing this for a while, lots of times you have problems and complications. That doesn't kill the person. What kills the person is the response to that problem. And so take a breath, think about it, make a good choice. I'm not at all embarrassed about a 4% conversion rate in this group of patients. Very few had intraoperative blood and very few had postoperative blood. We had 4% went back for bleeding. Atrial fibrillation rate was 20%. So we've had a couple of re-ops, and I unfortunately have a reasonably large experience with a trifecta valve, much to my chagrin. So we've lived with this problem for a while. I put in, I don't know, maybe 100 of them, which is, terrible. But all the reinterventions that we've had have been on trifectas. In terms of long-term survival, we don't have 100% follow-up, but in the people that we followed for a lengthy period of time, the average follow-up being 58, we had low mortality rate. We have one in-hospital mortality, as we point out there. Everybody goes home. There were 4 people who went to a nursing home. One, as I pointed out, died. And the survival, 92% 5-year survival of the 27 patients that were out 5 years. So this is the case I'll present. It's a 71-year-old female, history of hypertension, dyslipidemia, type 2 diabetes. She had severe aortic stenosis, symptomatic, transthoracic echo 3 months prior to surgery showed an EF of 82%, severe aortic stenosis with a peak gradient of 81, mean gradient of 53, no AI. She did a lot of gardening and couldn't do it any longer because of exhaustion and shortness of breath. This is the pre-op echoes. You can see pretty calcified valve, no AI, tri-leaflet valve. Mean gradient was 57 on the echo. These are the dimensions. The aorta is relatively small. There's a hunk of calcium on the aorta. The annulus is relatively small. This is what it looks like. So the other thing I point out, and I've been going to all these meetings for a long time and been in a lot of minimally invasive meetings. Everybody shows a different picture. Everybody's picture looks the same. And the point of that is that this is a reproducible operation that everybody can do. And if you set it up the same way, which we all do, my picture looks the same as everybody else's picture. The setup is reliable and predictable. So we measured to whatever we measured, I'm not sure. So we're making an incision right at the commissure between left and non. We're wiring it underneath the left sinus towards the commissure, again, wiring it the other direction. I use the Y incision almost all the time, unless I really don't need to enlarge it very much. I use a HemoShield graft because I like the curve to it. So instead of a pericardial patch or a HemoShield patch, I use the graft because it makes it a little bit easier to sew. I start at the very bottom, in the middle of that incision, sew it into the graft, and basically just run it. The only thing you have to be careful of, and this is true, I don't care how you do the annular enlargement, whether it's sternotomy or not, you've got to make sure that suture line is hemostatic, especially below where you seat the valve, because it's really problematic to try to fix. But it's not unique to a mini approach. And if you think about it, you're on the right side of the aorta from a minimally invasive operation. So you're not looking down and under, you're looking straight at the root of the aorta. I think once you get over the fear of this, I think it's easier to do it through a minimally invasive approach. And you inspect the suture line very carefully at this point. I carry it way up on the aorta because no matter how high up you go, you always seem to be not high enough when you put the valve in. And you got to complete the incision anyway, so you might as well go way up on it. So these are the stitches for the valve, the annular stitches for the valve. I start usually at the nadir of the left, no particular reason other than it sort of sets up the transition. And when you transition from annulus to dacron, I usually take one bite in the annulus and one bite in the dacron. I don't know that it matters, but that just seemed to be logical to me. Now we've completed the rest of these sutures, and I'm putting them on the rest of the dacron. And once you get to the dacron, you can go from inside and just take a bite. That's the simplest way. A lot of people go from outside the graft to inside, but I don't think it makes a lot of sense. You just take that mattress stitch and you have both needles in. And usually you can get 2 sizes better. Sometimes 3 if you want to be really aggressive. I use mostly pericardial valves for tissue valves. This is an Inspiris.
One question, if I may ask here. This is an excellent video that highlights the reproducibility and how this really is a very good approach. My question to you is, how do you ensure that you have adequate coronary heights to set the patient up for the next procedure, which is likely going to be a cath?
That's a great question. So that's one of the reasons why I do that left one first, because that's under the left main, and I make sure that I'm as low as possible with that bite. That's a really great point. Thank you.
And you really have to make sure that the left side is lower than the right in the non-convenient reserve.
Yeah.
Can you implant a mechanical valve with this technique?
I'm sorry?
Mechanical valve?
Oh, yeah.
With this?
Yeah. I use the Onyx for that, and it's the same technique.
Yeah, you obviously can't use a St. Jude because the leaflets themselves would be would impinge on the graft, but the Onyx is completely housed
inside
within,
the housing. Yeah.
But it is a bulkier valve to put in.
It is. I think the Onyx valve has some nuances that make it challenging to implant. So you have to be familiar with those nuances, because that flange has to be in the ventricle. And if it doesn't fit into the ventricle, that's problematic. But the nice thing about the Onyx, two things about the Onyx. One, its hemodynamics are better than the St. Jude because it opens to 180 degrees. But the other thing is, and I think this makes it almost mandatory to use the Onyx, is that you can reduce the INR level at 3 months, which has been shown in multiple studies to reduce the complication rate. And so you're really hard-pressed to say, I'm going to use a St. Jude valve that requires, by the IFU, an INR of 2.5 to 3.5, when you can use 1.5 to 2 with an Onyx that results in about a 70% reduction in anticoagulant-related complications. So I don't see why you'd use anything other than an Onyx based on that, until St. Jude does their own trial, which maybe they'll do it. That's the post-op result. I use a camera in everybody, too. I didn't point that out, but I've been using the camera forever.
But you do it by direct vision.
I do it by direct vision, but there's some parts of the operation where it may be easier with the camera because it's sometimes hard to see. But I use the camera. It's a great teaching tool for me because when the residents are doing their part of the operation, only one person can see with direct vision. But if you have a camera, I can watch these guys do the operation and yell at them.
Yeah, no, we've started using...
I'm pointing to one of my former residents, by the way, if you wonder who I'm pointing to.
We've been using the camera for the same purpose as you do, but the other thing that I find very useful for using the camera is that the entire room can see what's going on. Yeah. And so the whole team is engaged in the procedure as opposed to being
absolutely
distracted
true.
by something.
And the other thing that's nice about the camera, and I didn't show it here, but when I'm done, I drive the camera through the valve, and you can see the annulus and the sewing cuff in apposition. And if there's anything that you're concerned about, you can probe it and potentially put another stitch in. So it's a really nice quality improvement check, quality assurance tool. This is the post-op echo. So we got a 25 millimeter valve into this lady. And the gradients are 10 millimeters. That's it. Thanks.